reports are coming up. And if you have a very basic microbiological setup, with little more investment, you can learn how to make your own amniotic membrane. Thank you very much. And I'll be inviting my next speaker, Dr. Tuhin Chowdhury, for his part of the talk.
Back to Asbedike. Can you slideshow? All right. Everyone, at the outset, my sincere thanks to Soham for the opportunity. So I'll be talking about these amniotic membrane transplantations in acute conditions like that, chemical and thermal injuries, and Stevens-Johnson syndrome and toxic epithelial necrolysis. So I have nothing to disclose about my financial interest. So whenever we are treating any patients with ocular burns, we have to promote this surgical therapy just to promote epithelialization of the cornea. So that can be achieved by either doing amniotic membrane transplantation that I will be discussing. So if you don't have amniotic membrane transplantations, then you can put large diameter bandage contact lens. Sometimes you can go for the stenoplasty, that is the stenon advancement flap. And even in some bad cases, we can go for limbal stem cell transplantation and conjunctival transplantation. So amniotic membrane can be used both as a graft, that is when this epithelial side is up. And it provides as a basement membrane for the epithelialization and or as a patch when this epithelial surface is down. And that way it acts as a biological bandage contact lens. It helps to, in ocular surface reconstruction, promotes rapid epithelial healing, and restores limbal stem cell function to some extent. So this is the surgical video. This is a 8-year-old child who had a Chuna injury. So you can see this fornix totally necrosed. This patient came 2 days after this injury. So in all these cases, we have to remove all those Chuna particles along with necrosed this conjunctival tissues. So this is almost near about grade 6 chemical injuries, and in amniotic membrane transplantations in chemical injuries, it should be advised only in grade 3 to grade 6 as per the world classifications. Grade 1 to grade 2, that means treated only by medical treatment. So first I have to go for this 360-degree congenital peritomy, and then putting this amniotic membrane. Here it will be as a graft, that epithelial side is up. So I am putting this fibrin glue. And then you have to just undermine inside this conjunctival peritomy. And in children, whenever you are putting this amniotic membrane, you should put that means suture. You can put either this tenonylon circumferential suture over this at the limbus, or you can put this you just suture it. These peritomy areas can be sutured by using Chevron Vicryl sutures. Because children will rub and sometimes it may dislodge. Now, these fornicial defects, we have to put another piece of amniotic membrane. Whenever we are putting 2 layers of amniotic membrane, at least the inferior layer should be sutured all the time. So here the superior layer, that I am just putting this fibrin glue, and then this conformer, so that it is allow this adherence of this amniotic membrane over the fornix. And in children, all time you should put this suture tarsorrhaphy, and that should be removed after 2 to 3 weeks time. So this is the picture after 6 months. So this patient needs some sort of, there is no this simleferon or anything like that. and there is no abduction or reduction defects, no ocular restrictions, anything like that. So if you don't have any sort of this fibrin glue, then you can use either Prolene suture or 40 silk sutures, which will be tied over the bolsters, and the suture should be passed from the fornix and tied over the bolsters here. And then you have to, so this is this, here I am putting this 40 silk suture. You can use this Prolene suture and put it over the bolsters. And in the lead margins, you can use this nylon suture. This is the schematic diagram. So here this is this. Here this is this 40 silk suture, and here this is this nylon suture. So, but always remember that in presence of scleral ischemia, that is this blanched out white appearing sclera, where only this amniotic membrane transplantation will not help. So in these patients, you have to go for tenonplasty. So this is the area where you can see that this is blanched out. This is scleral ischemia. So here only amniotic membrane transplantation will not help. So you have to go for tenonplasty. That is tenon absorbent flap. So what this in 1989, Tipping and Ream first reported tenonplasty, where it will act as a pedicle graft to halt the progressive scleral melt, and that way it facilitates a conjunctival healing. So you can see that this is the patient who had this scleral ischemia. So you have to take this pedicle tenon graft from here and suture it in the limbus. Okay. So that way this scleral ischemic part will be, that ischemia part will be restored, that blood circulation will be restored. So sometimes what happens, if you want to go for this tenonplasty, this is the patient, he had this thermal injury. It came to us after near about 3 weeks. So this patient had this scleral ischemia and this sclera is bit charred. So what to do? I have to put a layer of amniotic membrane over this charred tissue because I cannot suture it in the limbus here. So after just you have to separate the tenons tissue from the overlying conjunctiva and from the underlying that means sclera. Also you have to separate it from the this extraocular muscles. And whenever you are taking it, you should not pull it much because that will cause this fornicial shortening. So I am putting this over this necrosed area of sclera, putting a piece of amniotic membrane, and then suturing this tenons and flap over the amniotic membrane. Then just putting suturing these tenons over that amniotic membrane, then putting another piece of amniotic membrane here. And then conjunctival defect will be sutured. In all these cases, we have to put a bandage contact lenses. And now these patients came after 10 days. So this ischemic part is getting better. And after 3 weeks, you can see that ischemic part is getting, that means this vascularization has started now. So this is after 6 weeks, this patient developed this large epithelial defect. So at this visit, I started this patient on this autologous serum, 20%. And this is after 3 months, that ischemic part is getting better now. And now after 6 months, that there is no scleral ischemia. So there is vascularization, but this patient developed some sort of scarring. So at this visit, I asked the patient for penetrating keratoplasty, but patient just didn't want to go for that. But patient came after 2 years. You can see that the picture now, that there is remodeling of the cornea, and this patient has improved almost 636. Now another, if this use of amniotic membrane is in acute condition is Stevens-Johnson syndrome. And aggressive control of ocular surface inflammation, especially with AMT during the first week of acute Stevens-Johnson syndrome, is most important. And amniotic membrane transplantation along with intensive corticosteroid therapy is the mainstay of treatment. And that way it significantly reduces the incidence of severe ocular surface scarring and longer term visual complications. And it is crucial that all ophthalmologists be actively involved early in the treatment process, as there is a limited window of opportunity for preventing ocular surface damage. This is a patient. This patient was, that means my friend, he's a doctor of medicine, and his teacher got affected and was admitted in Apollo in 2011. So all patients with acute SJs should be examined urgently by an ophthalmologist. So because that he knew about these complications, so he called me. And what I did this at bedside, I did this amniotic membrane transplantation. So at that time I didn't put any sort of fibrin glue, I just put this amniotic membrane over the ocular surface and put a symblepharon ring. So all patients should be examined by ophthalmologists. So this is the pre-op picture, and AMT should be done as soon as possible in acute SJs or 10 within first week, preferably within 3 days. Before the onset of fibrinous inflammatory exudates, they will get collected in the fornicial area, and then that leads to cicatrix or symblepharon formation. So you can see that because it was done very in urgent basis at bedside. So this is the patient. Even after 10 years, there is no lid margin keratinization or chronic SJs development. So this is the pre-op picture and this is the post-op picture. So any patients, as I mentioned, that with SJs or 10 who has eyelid margin involvement in the acute phase should have AMT, as I showed earlier. Also other signs like that, patients who have pseudomembranes and tarsal conjunctival or fornicial defects, because that defects will be fusing together, so you should go for AMT. So whenever you are putting this AMT, you should cover all the areas, starting from the lid, then tarsal conjunctiva, then fornicial conjunctiva, then bulbar conjunctiva, then this corneal surface. So this is the picture where it was just putting this AMT, and then they are putting this ocular surface with a symblepharon ring in this case, and they have put another indigenous silver ring by IV tubing to keep the membrane deep in the fornices, and then you can also suture it. If you don't have those things, then you can suture it and put this deep IV tubing also. The mechanism of AMT's beneficial effects is by minimizing the destructive effects of inflammation, by maintaining a healthier mucosa and eyelid structure. And while applying HAMs during the acute phase, it is important to cover as much as possible, as I mentioned it. And these techniques often necessitate the use of operating, that means room or microscope. So even you can, in these cases, if you don't have these facilities, then you can just put it like this way only. This is another technique. This was reported by Swapna Sanbag et al. So what they did that, they took this amniotic membrane and then put this cyanoacrylate glue over this area, and then they sutured, they put this amniotic membrane over this area, and then put this symblepharon ring or this IV tubing, and then dip in the fornix, and then again put this glue here, and then put this amniotic membrane over that. And this glued AMT is quite good and offers an alternative to the traditional sutured AMT, and it is painless bedside technique that can eliminate the need of general anesthesia. And the long-term ocular outcome appears to be equivalent to published sutured AMT data. Sutureless AMT, that is this Procera. So what is Procera? This is basically a spread of amniotic membrane over a polycarbonate ring. And this polycarbonate ring may be, in infant it is 15 millimeter, and in adult it is 16 millimeter, this diameter, outer diameter. And Procera Plus is the cryopreserved amniotic membrane which is fastened up to an ophthalmic conformer. The inner diameter is 15.5, outer diameter is 21.6, and the height of this conformer is 2.6. This is the sutureless AMT, this Dr. Bhaskar Chowdhury. This is from the silicon tubing, silicon ring, and just it is snugly fitted. is quite malleable and can be fitted in the deep fornix also. So this amniotic membrane is spread over the outer ring. And the inner ring is placed, and that way this is called M-setter, and it can be placed without any anesthesia at bedside. So it has been found that all the data showed that patients with, that means who didn't have AMT, they have poorer best corrected visual acuity, less than 20/200, even in 1 to 3 months post-operatively. And those who are having AMT, even long term also, the outcomes of visual acuity is quite better in comparison to no AMT. And on all the studies, they showed that there is minimal or no nil complications. And Procura may not prevent these cicatricial complications in fornix. So Procura just gives only superficial area, but it will not go to deep. Even Procura plus also it won't go deep. So in these cases, the best is that you just use this aim shutter or anything like that, it will go deep in the fornix. So to conclude, AMT has certainly an acceptable position in the surgical armamentarium of the ocular surface surgeon. Relative ease of the procedure, repeatability, and freedom from intraocular intervention makes it quite attractive surgical option. And it is crucial that all ophthalmologists be actively involved early in the treatment process of the, as there is a limited window of opportunity for preventing ocular surface damage. In the meantime, if you have any questions, I can answer that also.
Yes, thank you so much, Dr. Chowdhury.